The title of this module is Social Neglect-Related Disorders. And the objectives of this module are first to describe the signs and symptoms of social neglect-related disorders, next to describe the prevalence, development, course, and risk factors for these disorders, and finally to differentiate social neglect-related disorders from other stress and trauma-related disorders. And the two disorders that we'll be focusing on today are reactive attachment disorder and disinhibited social engagement disorder. So before considering the diagnostic criteria for these disorders, it's important to understand the types of events to which these disorders are anchored. Now, neglect can be broadly defined as the failure of a parent or caregiver to provide for a child's basic needs within different domains. So it could involve, for example, failure to provide food, shelter, or appropriate supervision. It could be a failure to provide necessary medical treatment or to provide education. It could also involve inattention to a child's emotional needs, failure to provide psychological care, and permitting a child to use alcohol or drugs. Now, neglect is by far the most prevalent form of childhood maltreatment, with rates far exceeding those of physical abuse and sexual abuse, for example. And when considering social neglect in particular, it's important to understand this concept of serve and return. So there are reciprocal interactions that occur between children and adults, with children communicating through babbling and facial expressions, and adults responding to those communications with similar vocalizations and gestures. And that serve and return is really important for brain development and for later learning. And when there are disruptions in that serve and return, for example, when caregivers are unresponsive to children, that can be associated with increased risk for a variety of problems for the child, including cognitive problems, academic delays, impairments in executive functioning, and dysregulated stress response systems. So the diagnostic criteria for reactive attachment disorder include, first, a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers that is evident in both the child rarely or minimally seeking comfort when distressed, as well as the child rarely or minimally responding to comfort when distressed. In addition, there are persistent social and emotional disturbances that are characterized by at least two of the following: minimal social and emotional responsiveness to others, limited positive affect, as well as episodes of unexplained irritability, sadness, or fearfulness, even during non-threatening interactions with adult caregivers. In addition, the child has experienced a pattern of extremes of insufficient care, as evidenced by one or more of the following: social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults, or repeated changes of primary caregivers that limit opportunities to form stable attachments, for example, frequent changes in foster care, or rearing in unusual settings that severely limit opportunities to form selective attachments, for example, children who are raised in institutions with high child-to-caregiver ratios. Now, Criterion D stipulates that the care in Criterion C that we just went over is presumed to be responsible for the disturbed behavior in Criterion A. Further, the criteria are not met for autism spectrum disorder, that would be a rule-out, and disturbance is evident before the age of 5 and for children who have a developmental age of at least 9 months. Now, for disinhibited social engagement disorder, the criteria are as follows. First, a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults with at least two of the following symptoms: reduced or absent reticence in approaching and interacting with unfamiliar adults, overly familiar verbal or physical behavior that is not consistent with cultural norms or with age-appropriate social boundaries, diminished or absent checking back with adult caregivers after venturing away, even in unfamiliar settings, and a willingness to go off with unfamiliar adults with minimal or no hesitation. Criterion B posits that the behaviors in Criterion A are not limited to impulsivity, as might be seen in attention deficit hyperactivity disorder, but include a socially disinhibited behavior. Now, similar to reactive attachment disorder, disinhibited social engagement disorder is anchored, as it were, to these experiences of, or these extremes of insufficient care. and these are the same: the social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults, repeated changes of primary caregivers that limit opportunities to form stable attachments, as well as rearing in unusual settings that severely limit opportunities to form selective attachments. And similar to reactive attachment disorder, the care in criterion C is presumed to be responsible for the disturbed behavior highlighted in criterion A. For disinhibited social engagement disorder, the child must also have a developmental age of at least 9 months. So let's talk about differential diagnosis here. When contrasting reactive attachment disorder with autism spectrum disorder, in reactive attachment, you really want to see a history of neglect here, as well as an atypical pattern of attachment behaviors, whereas in autism spectrum disorder, you'd expect to see restricted interests or ritualized behaviors, as well as social communication deficits. Now, to distinguish disinhibited social engagement disorder from ADHD, you really want to show that with disinhibited social engagement disorder, the social impulsivity is there, but not difficulties with attention or hyperactivity as would be seen with ADHD. So when focusing on prevalence and treatment here, reactive attachment disorder is quite rare. It's presumed to have a prevalence of less than 10% even among severely neglected children. And treatment typically involves removal from an abusive or neglectful home, wherever applicable, as well as remediation through stable, nurturing caregiving environments. The prevalence of disinhibited social engagement disorder is unknown. However, it's suspected that as many as 20% of these really high-risk children who are in foster care or raised in institutions may meet criteria. Treatment involves remediation through stable and nurturing caregiving environments, similar to reactive attachment disorder. However, with disinhibited social engagement disorder, symptoms often persist even through adolescence following this remediation. So this table here is useful, I think, for considering different types of unresponsive care and the interventions that may be appropriate for these different types of care. So with occasional inattention that may occur in otherwise very responsive environments, no intervention is needed. In the case of chronic understimulation, interventions may want to address the needs of the caregivers. These may be overwhelmed caregivers, unable to give the attention that their children require, as well as aspects of interventions that are focusing on high-quality early care and education for the children. Now, when the neglect is more severe and occurs in family contexts, interventions may focus on training caregivers to be more responsive to their children's needs. And when the severe neglect occurs in institutional settings, interventions typically require removal to stable, caring, and socially responsive environments as soon as possible. Now, for additional resources, please see this working paper developed by the National Scientific Council on the Developing Child, as well as these additional stress and trauma-related disorders modules.